Afternoon and welcome to another edition of the Be Mobile Show with Brody and Jack. We are the physio experts in all things health and fitness for those 55 plus. And today, Jack, we are talking about two of our least favorite phrases, wear and tear and bone on bone. And we're going to be myth busting each of those and talking in a wider sense about pain and the power of words.
Yeah, Brody, speaking of my least favorite, I haven't sold a single copy of my new autobiography that's just come out, everybody.
Yeah.
It's a story of my life.
Yeah.
All the time. Anyway, we'll have to see how that goes. You can grab that on Amazon, folks.
What's that? You got a snappy title?
Yeah. It's
Jack.
Jack. Yeah.
Jack. Alive.
I'm copying AB Facey's
Yeah.
A Fortunate Life.
Yeah.
But I'm now thinking it's an unfortunate life. No, only joking. And listen, Brody, we've already got some people commenting.
Hello.
Palmer, hello, how are you? She's already in on the comments, so good to see some people
Got in there early.
Get in your comments, folks. Remember, after the education segment, we do have a live Q&A section where you can ask any question that you want, including our favorite colors, so on and so forth. So,
And we'll do our best to answer those.
yeah, 100%.
If we can.
Generally. Great.
I mean,
And
possible
Gillian's
you'd ask
already
a-
saying hello.
It's
Hello,
possible,
Gillian.
albeit unlikely, you'll ask a question I don't know the answer to.
Yes.
Pretty unlikely, but you might find
It's never happened so far,
Yeah.
but we'll see if we can get that going. So, folks, today we are talking about the power of words.
Yeah.
Okay. I mean, actions are always the best thing. Like, you know, in terms of doing things, always spark the most amount of change in life. But words can also have big impact.
Oh, yeah.
And we're quite big on this at Be Mobile because we understand pain a lot more than your average Joe.
Yeah.
And we understand that words affect your pain experience a lot more than you possibly think.
Yeah, so how do we get there? We have to start with the fact that pain is not an accurate representation of tissue damage.
Hang on, BMO.
Yeah.
You're going to have to explain that because most people are thinking
Yeah.
pain, obviously that equals damage.
Yeah, not always the case. Pain is your brain's attempt to make sense of the inputs coming into it at any one time. And it judges those inputs and considers how threatened you are and a bunch of other factors and decides whether pain is necessary. So it's not just as simple as X damage equals X pain. The brain's doing a lot of filtering and understanding. So crucially, your brain might decide there is harm and you have a pain response, but this doesn't mean there actually is harm. Our brains can be misled and manipulated into feeling pain when there maybe isn't necessary risk of damage.
Yeah, great. Okay, that's really interesting. Can we give an example? I think we might even be able to give an example of how you might have a pain experience, but you're not actually getting pain, or vice versa. You've had some serious damage, but you're feeling nothing.
Yeah, so you might touch a hot stove and it might hurt immediately. But if you pull your hand away quick enough, often there's no damage, there's no burning at all. So that pain response has done its job of protecting you, of getting you to avoid any actual significant damage. Or something like a paper cut, for example, is just an example of pain being disproportionate. Anyone who's had a paper cut knows how it can be really surprisingly painful for something that is such little damage and such little threat to your well-being.
Yeah, that's right. Or if you want to go to the extreme of people not feeling pain, like you might have someone who's shot in a war, in a very stressful situation, that actually don't notice they have been shot till after they've got out of a certain stressful situation. You hear stories of this all the time from soldiers. So that's a really interesting one. You couldn't have more damage.
So we could talk about this for a long time, but the key idea is that pain's not an accurate representation of damage, and it's influenced by lots of things: social, cultural, psychological factors. And this includes the things we say and believe about our bodies. Our beliefs are really important. And that's why, Jack, we want to address some of these phrases. So I'm sure we've all heard of wear and tear before. And bone on bone is something many of our clients and members say and things we've heard.
Yeah, for sure. And as we've already discussed, but we'll just really reiterate it, that there's two big reasons why they're problematic. Is one, they're not accurate, which is what we're going to discuss. Two, they influence the way we feel. And just, you know, as an analogy as well, like if you say, you know, I'm going to have a really bad day today, and you keep saying that to yourself, you're more likely to have a bad day and get the blues, okay? So words can have impact.
So
Brody, let's talk about bone on
yeah,
bone.
like does hearing that your knee is bone on bone empower you to be strong and resilient and to exercise and be healthy? Or does it make you feel like your knee is fragile and you're concerned about exercising because it's going to damage it? So, for example, with osteoarthritis, which is often the reason people get told they have bone on bone, we know that exercise is highly beneficial for improving their function, their well-being, their health. So why would we health professionals tell people something that's going to make them feel fragile and think of their body in negative ways to make them less likely to exercise? That's why bone on bone is a pet peeve of ours. That's why we really don't like it when we hear it coming from other health professionals.
Well, and I was just going to, I'll jump in there and say, I wonder if many of our audience have been told when they've been to the doctor before or the surgeon, oh, wow, it looks like you have bone on bone, or there is a lot of wear and tear. Let us know in the comments, because this is something we like. How many times a day do we hear this?
And like just head in hand when like slapping my forehead when I hear of a health professional or a surgeon telling someone that knee's bone on bone, that's worn out, that's the worst knee I've ever seen. You've got the knee of an 80-year-old.
You'll never walk again.
Like ridiculous things to tell somebody, and really frustrates us. We're going to talk a bit more about the specifics and use a bit of evidence to bust those phrases, just so you don't just have to take our word for it. We're going to use some evidence.
Let's get the myth busting gloves on, and let's bust and dust.
Was myth busting a phrase before the show Mythbusters, do you think, or did they really bring that? If anyone knows, Mythbusters is one of my favorite TV shows. It's awesome. It's probably started.
It's basically where they bust myths.
It started about 20 years ago, I would guess, and ran for 10 or 12 years on the Discovery Channel.
I reckon it's been a term for a long time.
Maybe it's been a term for it. If anyone knows in the comments, if Mythbusters predate that show, or did that show really?
Hard hitting questions here at Be Mobile. But
anyway, let's
talk about wear and tear.
Yeah.
And as I said in the comments, if you've ever been told you have heaps of wear and tear in your knee, back, whatever it is, or bone on bone, let us know in the comments. I bet we've got a few people who have.
So,
Brody, is wear and tear accurate?
No. So this implies our bodies wear out with normal use.
Like a car or something.
Like a car part, or some mechanical door hinge or something that's just going to, over time, wear and tear until it doesn't function anymore. But this is not true, of course. We are living, adapting, changing organisms. Yes, our body changes with age. Yes, joint cartilage in your knees and hips tends to be thinner as you age. But this is not correlated with pain or disability. This doesn't mean you will have pain or disability. In fact, research shows that the body parts that we use more often actually show less of these age-related changes. And we're going to talk about a specific example.
Well, do you want to start with that example now? There's some good evidence regarding recreational marathon runners, which I think, because, I mean, if you were to pick any sport, marathon running, 42 kilometers, slapping the pavement,
pounding
that must be terrible for your knees,
right? That must wear out your knees, right? No, because we adapt. So this great study from 2018 took nearly 700 recreational marathon runners whose average age was 48. And they looked at their rates of hip and knee osteoarthritis, how thick their cartilage was, how healthy their hips and knees were. The prevalence of hip and knee arthritis in these recreational marathon runners was 8.8%, which is much, much lower than the age-matched non-marathon runners who have a rates of arthritis of 17.9%. So less than half the rates of hip and knee arthritis in people who regularly run marathons compared to average healthy people that don't.
And this is a really important point here. There was no significant risk associated with increased running duration, intensity, mileage, or total number of marathons completed. Because you would think, oh, maybe it's just because they've done 3 or 4 each. But what about when they get to 20 marathons? Well, unfortunately, the evidence shows that actually it doesn't really matter.
So the people in that study that ran the hardest, the furthest, and that had accumulated the most marathons completed in their life did not have higher rates of arthritis in their hips or knees. So this really shows us that a good example of how our bodies do not wear out with repeated use. Cartilage can recover and heal and repair and adapt.
Yeah, and we like to think of it, rather than wear and tear, as wear and repair.
Yeah,
that's a lot better way to think of it. And also not just a lot nicer, it is more
accurate. Both more accurate and more positive and affirming. So next time you hear someone or you catch yourself thinking in terms of wear and tear, change that to wear and repair. Because yes, loads can stress our body, but our body is really good at repairing and adapting and getting stronger and better. So no more wear and tear, people. We're not having it.
And we've got a couple of comments here. Carol says, I've been told by the radiographer and physio that my knees are bone on bone and I'll never get back to tennis. Carol, we're about to talk about that phrase, bone on bone. So make sure you listen up because we think that's not a great thing for any practitioner to tell any client.
Get a different physio.
Yes, I would recommend that. And Leslie says, this is good to know and understand. I feel empowered to stand up against the medical practitioners who push for surgery and joint replacements. Yeah. And, like I would say, for some people, it is definitely warranted surgery.
Oh, yeah. We're not saying never get a joint replacement. Definitely arthritis gets to the point for people that it is absolutely valid and necessary.
But it's not a first-line treatment. No. I completely agree.
There's a lot you can do first and what you should try first.
Okay. All right. Well, let's...
Shall we get to bone on bone?
There are more comments streaming through, Brody, but I think we should get to bone on bone. Considering Carol was just told that she has bone on bone, she's never going to be able to play tennis again. I think that's a horrible thing to say. Let's, not for Carol to say, for the practitioners to say, let's get onto this phrase.
So what does it imply?
So this implies we've got, and let's specifically talk about, because this could be shoulder joint, it could be any joints really where we have bone on bone contact, but it's implying that there's no space, let's take the knee joint, no space between the knee and, it's grinding and cracking on each other.
Doesn't paint a very nice picture, does it?
But firstly, let's just say that generally speaking, bony joints are technically bone on bone. There is obviously cartilage and other things in between, but our bones do touch other bones.
Yeah, and that's
nothing
fine.
wrong with that.
They're meant to do that. That's normal. So, bone on bone is not good and not true because all joints have cartilage.
Yep.
As we said, cartilage thinning does occur with age. Joint space is typically narrow with
normal.
age, but that is normal. It's a normal part of aging. It does not mean you will have pain or disability necessarily. So even joints that look like bone on scans can be completely healthy and pain-free. We're going to talk about some evidence, but actually there's another study I will just even more briefly mention.
Let's go for it,
which is they looked at people with diagnosed osteoarthritis in their knees, and there's 4 grades. Grade 4 is the worst, of people that had grade 4 arthritis on imaging. So the most bone on bone, the worst it can look on imaging, 32% had no pain or disability. So a big chunk still did, of course, but 30%, a third of people with the worst bone on bone you can have on scans have no pain or disability. So that's pretty powerful.
That is very interesting. Should we touch this other piece?
We'll have a bit more info on this next one.
So there's a 2019 meta-analysis. Brady, do you want to quickly explain? I'm terrible at explaining this. Do you want to explain what a meta-analysis is?
In research, a randomized controlled trial is the best type of study.
Yep.
A systematic review with meta-analysis is when they look at all the available randomized controlled trials on a certain topic.
Yep.
Do an independent analysis of the quality and discard the ones that are not good quality, and then just analyze all the data in one big set. So it's how we get to the best, most most robust conclusions about anything in health and medicine.
And it allows us to bring randomized control trials, which might have 100 people in it, and get 100 of them, so we have 10,000 people in it instead. So,
and in the case of this study, they looked at 5,300 knees, 5,300 knees from across 63 studies of osteoarthritis.
Brody, what did they find?
On average, the rates of osteoarthritis features in asymptomatic, uninjured knees. So asymptomatic, no symptoms, no pain, no stiffness, no disability, uninjured, no history of injury, was 19 to 43% of adults over 40. So between 19 and 43% of adults over 40 have osteoarthritis features on a scan and have no injury, no pain, no disability, no stiffness, no nothing. Perfectly healthy knees. And this goes up with age. In people over 70 years old, 75% of people over 70 years old have these same features. When we do imaging of their knees, no pain or disability or stiffness.
So once again, this reflects normal age-related changes that don't necessarily come along with pain and other symptoms.
And I've pulled out a couple of quotes about the study because the authors of this study were very much pushing the view that we do way too much scanning of people's knees, too much MRIs and X-rays and things of people's knees and hips, because all these scans show these normal findings, so they're not really that useful. So a couple of quotes from the study. The author said, management of osteoarthritis should center on improving symptoms and functional limitations and not be driven by imaging findings. Right? So they're saying, do not worry about what the image says. Don't worry if the image says you've got bone on bone, forget that. Just care about your current function and symptoms, which can be improved.
Yep.
The other thing this study said is the explosion of MRI use over the past 2 decades has not resulted in improved treatment decisions or outcomes with knee pain. So all these MRIs aren't helping us.
Yep. Okay.
Great.
I think they're really powerful quotes, and I just put them up there.
Lovely. So bone on bone itself is nothing to worry about. Forget that phrase, stop using it. If a medical professional tells you that phrase, maybe look for a different medical professional because they're not doing a great job of empowering you to look after your own health.
I would agree. In fact, Sarah says, I re-educated someone who regularly used this term with wear and repair.
Yeah, go
Thanks,
Sarah.
team. No worries, Sarah. I think that's completely your thing to do. If you've learned that, I think challenging people around you and challenging health practitioners as well, if they say that, is really important.
So that all that said, it's not to disregard if you have osteoarthritis and you have pain and difficulties and limitations. Of course, those are still valid, and they're something that you can and should be addressing and looking for ways to improve. Of course, exercise is a great one for doing that. Weight management, other aspects of your health, which we've talked about many times in relation to osteoarthritis. So the pain and disability and function that you might feel is all valid, but we just don't want to be using these phrases that paint this negative picture of our body and make it feel like it can't recover and improve, because it can.
Yeah, 100%.
Good-o.
And it's interesting because, we will often say, be careful how you speak around kids, for example, because they take that on, but we don't think about ourselves when it comes
how we speak
to
about ourselves.
Yeah, how we speak about ourselves. So that little inner monologue, whenever you catch yourself talking in your own head a certain way, think, well, is that actually true? And if you want to find out whether it is or not, you can also ask us.
Yeah.
Because we're always happy to debate some of those inner monologues.
So back to Carol's point, we haven't assessed you individually. I don't know whether or not, like, how realistic getting back to tennis is with you, but your scan showing bone on bone quote is not a reason to not get back to tennis. I'd be telling you, let's work towards getting back to tennis.
And
let's
Carol
build strength and fitness and ability. Yeah.
Sorry, mate. Carol did say my knees were sore and swollen to twice the size, which is why I went to the doctor. Yeah. So that's obviously
there's probably some valid signs
symptoms.
of osteoarthritis there, which is fair enough. But yeah, that's not enough. What the scan says is not enough reason to think you can't get back to tennis. You may not be able to. I'm not saying you definitely can. I don't know your individual situation in enough detail. But yeah, that's not enough reason to think you can't get back to tennis. You can improve your strength, stability of the knee, ability to move around, etc.
Yeah. And also, who wants a message like that compared to a message of hope where it's like, well, like, we're doctors, we're physios, but we can actually try to help you get back there.
Because exercise
let's not give up.
and weight loss and education does help improve arthritis symptoms and does allow people to get back to things they weren't doing.
Okay. Well, thank you very much, everyone. And Helen comes in here with a comment. She says, thank you for this. From what you were saying, if I am in a little pain with my knee when jogging slowly, can this improve if I keep going? My doc also said I should stop. And that's a really interesting question. So I would say, no, don't stop at the first hint of pain. I would say managing your pain, or you probably heard the term pain management lots of times, but I would think of it more as load management. So if you're running for, let's just say 10 minutes at a slow pace and you get the onset of pain after 10 minutes, or some days it's 15 minutes, well, then I would pull back a little bit, maybe do a little bit more walk-run ratios. So like, for example, 1 minute walking, 1 minute running, 1 minute walking, so that you're just changing the overall load and stress on your knee joint and slowly building up over time. But like, running's so good, such a good thing for you. So I wouldn't give that up.
Yeah. Depending on your situation, there's lots you can do. Lots you can do to address that. Yeah, so changing how much running you're doing, as Jack said, maybe backing off, maybe doing more frequent, shorter runs might be better, etc. And then, of course, working on strength outside of running, doing strengthening exercises, like in our program, doing squats, lunges, and things to build up the leg strength. So there's lots you can try and do.
And Brody, but Helen said, I'm in a little pain.
Yeah, little pain. Yeah.
Which is, like, if you can tolerate it, we would say keep going with what you're doing. And if it's not affecting you in the day after, and you're not hobbling around the day after, well, then I would keep going.
Yeah, sometimes it's okay to push on with a little bit of pain. Yeah.
Okay. Okay, we will get to some questions. Norma does have a question here, but before we do, Brody, well, so if you do have any questions about that, by the way, chuck them in the comments, or any other questions, we're happy to answer them if you get here live. But also, comment and let us know what other topics you'd like to hear about in these live education segments, because we want to serve you, our audience and community. And for all of our members, all our 8-week program members, just check your comment below. Tell us what you want to know about.
And we love this stuff. Obviously, it fascinates us. So there's lots we could just talk about. We got endless ideas, but we want to know what our listeners actually want to hear about and learn about. So we'll definitely tailor it to you if you have suggestions. So please let us know.
Great. All right. Well, let's just take a quick break. And I just want to say, we have a member challenge currently going on. So just as a reminder to our Be Mobile Online members, we are in the second week of the Spring into September challenge. It is ending this Friday. So make sure you are staying on track with all your workouts for this spring into September. We've had so many amazing photos in the group so far. So we really appreciate everyone's involvement, especially all the beautiful photos of the birds that people were posting over the last couple of days. I do appreciate that because there are a few UK birds over there that I haven't seen before. So and some cute little ducklings that someone took a photo of. That might have been New Zealand, actually.
Yeah.
Great. Okay, Brody, should we get
questions
into the Q&A? I'm going to start with Norma's question.
Yeah.
I'll get it up on screen. Norma says, I'm sorry if this question has been asked before, and don't ever say sorry, always ask. Don't worry if it's been asked before. But is there any benefit in taking collagen supplements? Norma, great question.
So the answer to this depends somewhat on what you would be taking them for, potentially. We've been talking about knee arthritis, hip arthritis type stuff today. So in that context, is there benefit? Not enough that it's been established to be like a guide, like in the guidelines for health professionals and stuff that are put out by health governing bodies and stuff. It's not a recommended treatment. So just from that sort of umbrella overview, we would say probably there's not enough evidence. I'm not that familiar with the evidence myself. I would have to be honest, this is a good thing I can go away and look into this a little bit further and speak more confidently about it. But I would just say in terms of musculoskeletal pain and things, as far as I'm aware, it's not a recommended treatment, so it hasn't been established enough. There may be some promising smaller trials, but I just don't know enough about that to answer thoroughly, Norma. But thanks for the question. That's something we can look into further.
Yeah, and one more general broad comment would be that for many supplements, you always want to think about like, what could I change in my diet?
Yeah.
What can I change about what I'm eating to increase whatever I'm trying to increase? So, for example, protein supplements are great, like protein shakes.
Yeah.
But if you can get all of the protein in your normal diet, we'll do that instead.
Yeah, and just generally speaking, like I'm pretty supplement skeptical in terms of most things. Like
fish oil and
most of these things have not been shown to work in good quality trials. And if you are, you're looking at these are like the small little slivers of percentage pieces of difference. The big 80% of benefit comes from just like the classic boring stuff: sleep, exercise, good diet, sleeping well, all that stuff. There may be slivers of benefit to certain supplements, but I mean, it's not what you should be focusing on.
And the supplement industry is a
big money making system.
Big money making system.
It pays to be a little bit skeptical.
Great. And listen, Brody, I just got to bring up Rita Sonk is tuning in here from Belgium.
That's awesome.
Good morning. Now, Rita, I don't think we've ever had anyone come in from Belgium. So thank you very much for joining us. I
went to Belgium last year briefly.
Oh, did you?
When I went to the Rugby World Cup in France, and then we drove up.
Tell Rita where you went.
Drove up through Belgium and the Netherlands. I can't remember the name of the town we went to in Belgium, but it was a beautiful little town where we stopped for lunch. I'm going to see if I can find it. Keep talking. I'm going to keep talking.
Well, great for joining us. Thank you. And thank you, everyone, for joining us. This is interesting. Ali says, when I was diagnosed with osteoarthritis and had problems with mobility, my GP said it was just part of getting older. Yeah, thanks for that comment, Ali. Brody, Ali's talking about when she was diagnosed with osteoarthritis and had problems with mobility. This was just part of getting older. So let's talk to this with a bit of nuance. So there certainly are things that happen as you get older, because we don't want to say age is just a number. There's nothing that happens. No, there are age-related changes. But what we're saying is a lot of these changes are normal. For example, decreased cartilage in the joint. And yes, you become, for example, reduction in strength and cardiovascular fitness generally happens in our 40s, 50s, 60s, so on and so forth. But what we're talking about is mitigating some of those things, and the fact that you're not necessarily going to have pain and symptoms when you do have things like bone on bone, according to scans.
Yeah. So osteoarthritis prevalence does increase with age. You're more likely to have osteoarthritis at 60 than at 20. Like, that is for sure a thing.
Yes. But it's just one factor.
And that doesn't mean you can't improve pain and function. The same with mobility. Yes, an average 80-year-old does not have the kind of mobility that someone in their 20s or 30s has. Of course, we all know that to be true. But again, that doesn't mean you can't be remarkably fit and athletic and capable at any age. look at like the Masters Olympics, for examples of people in their 80s and 90s doing incredible things, running, hurdling.
I just watched
jumping,
a 60-year-old run the 100 in I think 11 seconds.
Yes, ridiculous. I've never been that fast. Yeah, so you can be fit and strong and capable at any age, but of course, with aging, there are certain things that are just more likely and is more the norm.
But
saying it's just part of getting older, maybe in some sense true, but in a more important sense, just not very helpful or useful. What would be better to say is, you're having some of these problems, there are things you can do about it. Strengthening exercises to work on your legs and balance can improve your mobility. Your knee pain can be improved with weight management and exercise. So it's like giving solutions rather than just going, oh, you're just getting older, deal with it.
Like be helpful and hopeful. So give someone hope, not just, oh, no, this is just something you're going to have to live with. Thanks for the question, Ali. And Beryl says, I hurt my knee earlier this year and I had an ultrasound and the tech was talking about knee replacement. You see, Beryl, this is a classic example of so these people, firstly, if you're doing radiography, ultrasound, all that, if you haven't even assessed the person as well and you're a radiographer, you shouldn't be talking about this in front of the person, nor should you be. I mean, that's just a ridiculous comment anyway.
Radiographers and those sorts of people have an incredibly detailed understanding of anatomy and are highly specialized, skilled, important people in the medical community whose job is to analyze these imaging findings and discuss every little feature that they can identify. That is all very difficult, complicated, skillful work.
And they're looking for serious things like cancers, tumors, fractures, infections, things like that.
What they often lack is a nuanced understanding of what those features mean for a population in terms of pain and disability and function and prognosis. So there's a bit of an issue there.
Okay. Carol says, I'd like to hear about neck pain, limited movement in neck.
Yeah, great. That's a topic we can do I think these are topic suggestions for the future.
Neck pain.
We can do a deeper dive on neck pain in a future show. Thank you.
And Mo says, could you please discuss nerve flossing? That may be another recommendation.
Yeah, that could be a future show as well, for sure.
Yeah. Have you got any brief comments on it? I honestly, I don't have any. I know we learned some of this at uni to do with the upper limb, but I don't really have any comments.
Brain and spinal cord, nerves that spread out throughout the body to power muscles and things. Nerves exist in these sheaths that allow them to slide back and forward. Sometimes with nerve pain, these physios and stuff develop the idea of nerve flossing, which is these sort of gliding movements you can do the idea is to get the nerve moving to help with nerve pain. We can do a deeper dive looking at some of the research. My understanding is the effects of it are pretty underwhelming and haven't really been shown to be that robust. And so there's no condition I know of that it's sort of regularly recommended by the research as like an actual effective technique. Like anything, it probably helps for some people in some situations, but the idea of what it's doing is probably a bit overstated. But that's a good idea for a topic we could dive into a little bit further and really present some actual research on.
Great. And Sandra says, I'm concerned about lung capacity walking uphill, so would love that to be a topic. We've actually got some great videos coming out on our YouTube channel, Sandra, about walking capacity and how to improve your walking. So definitely keep your eye out for that. Actually, one thing I'll just quickly say about cardiovascular fitness as a whole, it's certainly something that you can continue to improve a lot longer. Like strength and power, like the speed of movement, tends to decline a bit quicker as we get into our 40s, so on and so forth. However, cardiovascular fitness, like you still see like 70-year-olds, 80-year-olds, even 90-year-olds completing Ironman triathlons and things like that. So it's pretty incredible.
Love it.
Great. And Maria says, can exercise aggravate migraines? Is rest or exercise best? Maria, Brody is your man of migraines because Brody suffers from them himself. So I'm going to let you tackle this.
I don't know how to answer this from like an evidence-based point of view because I actually don't know enough. Exercise has been shown, like strengthening exercise in particular and other forms of exercise in a long-term sense has been shown to help improve migraines, like reduce migraine. So people who exercise regularly, lift weights, do cardio training and stuff have less migraines and less severity of their migraines, but definitely doesn't cure them. In terms of exercising while you've got a migraine, I mean, I can barely sit up in bed when I've got one, so good luck. But I think in the long term, it helps reduce their incidence and severity, but it definitely isn't a panacea.
Yeah, and like anything, everyone's going to be different. So if you find exercise was the best thing for it, well, then it's probably the best thing to do for you. If you find rest is better.
I think in general, migraines are still pretty well not that understood, and triggers are so diverse and varied for different people. It's hard to say.
Yeah. And Maria goes on to say, as long as I exercise, my diagnosed severe osteoarthritis pains is in the main null and void.
Great.
So Maria, that's a great example of
Yeah.
you've been diagnosed with severe osteoarthritis, but you exercise, you stay active.
Yep.
I know you get outside a lot and do hikes, Maria. And so I think that's awesome. And then Carmel also says she'd love to hear about neck pain,
Yeah,
Brody.
cool. We'll do a deeper dive on that.
Okay. Great. Well, that's a lot of questions, a lot of comments. Hello,
good suggestions.
everybody.
Thank you
We've
for
got a
all
lot
the
of people saying
suggestions.
hello. Debbie, Norma, Leslie, Sandra, Sarah, Carol. We've got lots of people. Alicia, who's actually just behind the camera over there, she also says hello, everybody. So great to have you all on board.
Right? Yeah.
Cool. Great. I think that's about it.
That's about it. The town in Belgium I stopped for lunch was Ghent, Ghent.
I have heard of that.
Beautiful little town. Had a gorgeous lunch, had a nice beer, got back on the road. Lovely.
Beautiful.
I'll have to stay longer in Belgium next time I'm in that part of the world.
Yes, absolutely.
Mm.
All right, folks, that is all we have time for today. Got any more questions? No, that's all right. Hello, Val. She says, sorry, I'm late. Don't worry, but we are just about to go, unfortunately. But we did tell a joke at the start, so rewind to that. We'll see you next week. We're super pumped for that. And we'll put your recommendations for show topics in our notes. And I would actually really like to do that one about lung capacity. I think I'm going to tackle that one.
Yeah, go.
Great.
That'd be beautiful.
Okay, that's it from us.
Thanks for joining us,
Anything
everyone.
else to say, BMO?
No, we'll be back next Wednesday, 4 o'clock Sydney time, as usual, and we'll see you then.
Great to have you.